My presentation focuses on suicidality and suicide risk in transgender diverse young people. Three key claims are often made. one, that TGD youth are at very high risk of suicidality and suicide. Two, that this elevated risk is due to minority stress and or barriers to access to gender-affirming treatments. And three, that gender-affirming treatments decrease this risk. A parent reports being told, you can have a happy little boy or you could end up with a dead little girl. This parent seems not to have questioned the counsellor's advice. Now, of course, we can imagine how difficult it would be to be on the receiving end of such a statement and to ask questions and challenge it. What is your evidence for making such a claim? If the parent did, they might get a response, as a leading Australian gender clinician has recently claimed. There is robust empirical scientific research which supports affirming care and improving outcomes. Not providing medical and surgical interventions can result in severe mental health consequences such as depression, anxiety, self-harm and suicide. So what parent is going to be able to ask to look at the evidence and be in a position to evaluate such evidence, especially so given the widespread promotion of this narrative in the media, social media and via trans support groups? Auhowever, this is the task at hand for us today. What is the evidence for these three claims? This is what we need to consider in a manner suggested by authors of a recent book on suicide, and I quote, "Compassion has a very important place in any discussion of suicide, but it must be associated with a calm rationality. Only then will policymakers, politicians and societies be able to deal with it in a sensible manner." Two preliminary comments. First, talking and writing about suicide is not easy. Suicide is complex and an emotive issue. I'm a psychiatrist, and like most mental health professionals, I work with patients who are suicidal and some who tragically have taken their own lives. Not only am I a psychiatrist, but I've had my own lived experience. So I also know the difficult and complex emotional impact which, following suicide attempts and suicides, reverberate through family and friends and involved professionals. And I also know professionals are not immune from suicide. For example, data shows physicians have higher rates of suicide than the general population. So this is a reminder, if my talk does raise issues for any of you, please reach out to your personal and professional support networks and remember your local suicide lifeline numbers. Just a brief note on terminology. I'm going to use TGD to refer to transgender or gender dysphoric youth. GAT is to gender-affirming treatments. Suicidality is to suicidal thoughts and behaviours. And NSSI is to non-suicidal self-injury. So the first question is really, are TGD youth at elevated risk of suicidality and suicide? And the short answer is yes, from what we know. First, for suicidality, studies indicate a suicidality prevalence rate of 10 to 80% of surveyed TGD youth populations. These estimates vary widely due to differences in study methodologies and measures used, and there's also quite marked regional variations. The rates are higher, broadly 5 to 10 times that reported in non-clinical general population surveys. However, these estimates are reported similar to those of non-trans identifying youth referred to child and adolescent mental health services. Next to suicide. Although evidence is limited, studies also suggest elevated suicide rates. Biggs in a UK study reported 0.03% of the English youth gender clinics patients over a 10-year period died by suicide, which was 5.5 times higher than the UK population rates. In the Amsterdam clinic, a retrospective chart review reported 0.2% of TGD adolescents died by suicide. This suicide happened, the risks seemed to be at all stages of transition. The Belgian Youth Clinic reported 2.8% of the referred TGD adolescents seen between 2007 and 2016 died by suicide, all of whom had commenced hormonal treatments. In the Australian state of Victoria, which has a population of about 7 million, the Coroner's Court reported on suicides in LGBTIQ+ people 2012 to 2021. For under 18-year-olds, the suicides in absolute numbers range from 0 to 4 per year, and for 18 to 24-year-olds range from 1 to 9 per year. So remember, these figures are inclusive of all LGBTIQ plus identities. The Swedish National Board of Health and Welfare reported that the available evidence suggests suicide mortality in people with gender dysphoria is similar or less than people with psychiatric disorders. So in sum, suicidality and suicide risk in TGD youth appear to be higher than the risk in general population, but similar to adolescents referred to mental health clinics. Suicide is an infrequent but tragic outcome for TGD youth. The next question is, how do we understand or explain this elevated risk, and does gender-affirming treatment decrease this risk? The first point is that TGD youth have very high rates of comorbid mental health conditions, neurodevelopmental disorders, same-sex attraction and complex social issues. All these issues are independently associated with higher suicidality risk. Thus, the question becomes how we explain the elevated risk of all these issues. Gender clinicians tend to claim it is due to barriers to gender-affirming treatment and minority stress, but what is the evidence? Now, there are alternative theories, as I have noted in this slide here. So first, let's have a look at the lack of access or barriers to gender-affirming care. There's no reliable evidence that gender-affirming treatment decreases suicidality, and no evidence that it decreases suicide mortality in TGD youth or indeed adults. The UK's National Institute of Healthcare Excellence systematic review of the impact of puberty blockers and cross-sex hormones, as other speakers have mentioned, found that all the studies investigating the benefits or adverse effects of these interventions were poor quality and provided very low certainty evidence, and suicidality was one of the outcomes assessed. So there was no reliable evidence that these interventions decreased suicidality. A WPATH Commission systematic review on hormone therapy specifically noted there was insufficient evidence to allow conclusions to be drawn regarding the impact of hormone therapy on suicide mortality. One systematic review by Rue et al. Reported a link between puberty blockers and decreased adult suicidality had been found. However, following a published critique by myself and co-authors, they clarified they were not making any causal claims and emphasised that more rigorous studies were required. It's common to hear claims that a new study has demonstrated that gender-affirming treatment decreases suicidality, but I really recommend you read the details closely. I will provide a few illustrative examples. An Australian study reporting on the findings of a cross-sectional survey of transgender adults concluded that barriers to gender-affirming treatment was associated with increased suicidality in TGD people. However, reading this paper closely, it revealed that the conclusion was not supported by the study's findings. It had actually found that barriers to gender-affirming care was not associated with suicidality. The paper needed substantial correction and had to remove the initial key conclusion. I note, however, the original paper was cited in a letter to a parliamentary committee requesting increased availability to gender-affirming treatment, but I doubt the corrected paper was. A recent study from the UK of a retrospective observational analysis of 38 children assessed at baseline, 1 year post-puberty blockers and 1 year post-cross-sex hormones. The abstract reported a general decrease in suicidality and self-harm after treatment, but the word general rang alarm bells in my mind. And yes, indeed, behind a paywall, the main text reported there were 109 eligible participants, out of which 38 were included in the study, and out of these only 11 had completed the 2 suicidality self-harm questions. The authors noted that this low completion rate meant statistical significance could not be determined and no official conclusions regarding the impact of puberty blockers on suicidality and self-harm could be made. But clearly this did not prevent the authors implying in the abstract in front of the paywall that suicidality and self-harm improved following these treatments. Third, a US prospective study reporting on the psychosocial functioning of 315 TGD young people after 2 years of cross-sex hormones. The abstract reported the most common adverse event was suicidal ideation in 11 or 3.5% of the patients, and death by suicide occurred in 2 or 0.6%. The main text tells us little more about these results. However, the protocol reported that suicidal ideation scale with 8 questions was part of its questionnaire battery. The details of the findings from this questionnaire are not reported in the published paper. Why? We do not know. I submitted a letter to the editor to the journal asking about this. It was rejected, and as far as I know, 6 months later, no letter to the editors have been published. Just recently, a Lancet commentary by Dr. Resta of Yale University in support of the claims of mental health benefits of gender-affirming treatment cited this study, stating, notably this study also reported a total of 3.5% suicidal ideation, a comparable rate to the US general population rate of 4.6%, while others have questioned the accuracy of these comparison rates. Furthermore, this interpretation of the Chen paper's finding is not valid until we have the full suicide ideation scale findings are reported. And of course, even if it does find a reduction in suicidality, this study was an observational study with no comparison group and did not control for important confounders such as psychiatric medication, psychotherapy, or placebo effects. Additionally, it is notable that the Resta's commentary omits mention of the Chen study's 0.6% suicide rate over 2 years, which according to my calculations is approximately 20 times higher than the US general population rates. These examples illustrate what co-authors and I described in 2021 as a concerning trend to overstate the evidence underpinning clinical practice recommendations for youth with gender dysphoria. New publications reference prior ones with increasing and unwarranted confidence and with the risk of misleading clinicians regarding the state of evidence. There is also marked asymmetry in outcome reportings. Findings of positive outcomes of medical interventions are trumpeted in abstracts while their profound limitations remain behind the paywall and thus below the radar of busy clinicians. Let us now turn to some other factors which might be contributing to the elevated suicidality and suicide risk in TGD youth. Firstly, minority stress theory. This theory holds that the high incidence of mental health issues, adverse social circumstances and suicidality in TGD youth is a response to community stigma and victimisation. However, the evidence for the role of minority stress in LGBT suicidality is inconclusive. A recent meta-analysis by Hatchell and colleagues of suicidality correlates in LGBTQ youth reported the effect size for discrimination and stigma was small. Furthermore, suicidality is not consistently most common in the groups who experience the worst adversities. I think a further complexity to think about is whether we could consider that minority stress towards homosexuality, for example, discrimination and violence, might in some situations lead to a trans identification. And maybe this could be most starkly seen in countries such as Iran, where there's the death penalty for homosexuality, and some homosexuals undergo sexual reassignment surgery and thus becoming heterosexual and accepted within the community and avoiding death. Our next point is primary or independent co-occurring conditions. For example, as discussed, children diagnosed with gender dysphoria have high rates of autism, which itself is associated with higher suicidality rates. There is also a complex relationship between gender dysphoria and other factors such as adverse childhood events, trauma and mental illness. These conditions may predate gender dysphoria and be primary, contributing to both to suicidality and gender dysphoria in complex ways. For example, aversion to one's genitals or breasts may follow sexual abuse. Self-hatred, including internalised misogyny and internalised homophobia, can be expressed as hatred of aspects of the body or hatred of one's femininity or masculinity, and also may be features of depression and eating disorders, as well as gender dysphoria. I want to talk now about suicide script theory. This theory holds that suicidality is most likely when it is relatively acceptable and even expected for certain people given certain circumstances. According to this theory, suicidality has become an expected idiom of transgender youth's distress. It is written in the script of what it means to be transgender as a rite of passage, an expression of identity and belonging. Here we can consider nocebo harmful effects of clinicians and the media's communications to young people and their families. For example, clinicians making exaggerated claims that almost all TGD youth are suicidal and implying a young person will suicide if he or she does not receive affirmation or puberty blockers may act as a self-fulfilling prophecy and become an internalised suicide script in a young person, thus increasing their risk. Suicide behaviour diffuses through social networks via modelling. Suicide clusters are well known, for example, at schools and following media reports and fictional depictions. This is known as the Werther effect. The evidence indicates this is not just due to a shared risk, but that exposure to suicide does exacerbate a youth's vulnerability. Furthermore, social learning theory argues that through observations of others, we learn both behaviours and their perceived costs and benefits. This highlights that we must also consider there may be deliberate use of suicide claims or suicide attempts by a young person for the perceived gains of obtaining access to gender-affirming treatment. There are reports that this type of use of suicidality is encouraged by in-person or online trans community peers and even sometimes by clinicians. This parallels broader concerns about the role of online sick role subcultures might be playing in youth mental health issues. And it creates a difficult situation for parents and clinicians because just dismissing children's suicidal threats as demonstrative might actually then increase their risk of self-harm. Thus, a nuanced path that avoids labelling threats as demonstrative but also counters coerciveness is required. So, in sum, the current theories and evidence suggest there is a web of potential causal factors interacting in complex, non-linear ways underpinning the elevated suicidality and suicide risk in TGD youth, with different elements assuming more or less significance according to the individual context. I'll just make a few general points regarding the implications of the messaging around the suicide risk of TGD youth. First, an institutionalised narrative around suicide in TGD youth might be increasing suicidality risk in vulnerable young people by creating unhelpful social scripts, nocebo effects and self-fulfilling prophecy effects. Second, some of the messaging around suicidality and suicide in TGD youth is counter to the WHO's recommendations. For example, they recommend that we don't ever claim that suicide is the result of a single factor or event, and that factors that lead to an individual to suicide are multiple and complex and should not be reported in a simplistic way. And also, we should be clear, suicide is not a constructive or appropriate means of coping with problems, nor is it the only possible way to manage severe distress or to deal with adverse life circumstances. Thirdly, some gender clinicians make strong claims, unsupported by the weak evidence, that gender-affirming treatment decreases self-harm and suicide risk, and then make unwarranted strong practice recommendations, including implying that parents or other decision makers who decline to follow their recommendations are putting their children at risk. Such emotive statements without a high-level evidence base are concerning and place an unfair emotional burden upon concerned and cautious parents. In addition, such communications could be considered coercive and undermining of a true informed consent process. Instead, the clinician should truthfully discuss the weak and absent evidence and the controversy in support of the claims that gender-affirming treatment improves mental health and suicidality outcomes. They should empathise with the dilemmas faced by parents and young people, rather than presenting a one-sided position of certainty and suggesting that any parent who takes an alternative viewpoint or practice will cause the young person to self-harm or suicide. And these are my conclusions, but I think I've run out of time, so they're pretty self-evident. Click through that. Thank you, everyone.